Abnormal variant electrocardiogram in a hypokalemic patient. A case report by Dr. Zachary Bruss, Dr. Nicole Shumway, and Dr. Cameron Crandall from University of New Mexico Hospital Internal Medicine and Emergency Medicine Residencies. Introduction. Certain electrolyte abnormalities have the propensity to cause disruption in ion homeostasis at the level of pacemaking cardiomyocytes, creating consistent and often identifiable EKG patterns. The prevalence of hypokalemia in hospitalized patients ranges from 7% to 21%. Patients with severe hypokalemia generally have what is described as a U wave on their EKG, which is a smaller second wave but similar in appearance to the morphologic T wave that precedes it. The annual prevalence of hyperkalemia in the general population is 1.57%. Conversely, those with hyperkalemia may display what is characteristically described as a peak T wave. Both EKG changes are associated with the potential development of fatal arrhythmias. In this report, we describe a case of a hypokalemic patient whose EKG changes were more consistent with patterns of those with hyperkalemia. Moving on to our case, we have a 47-year-old female with a history of alcoholic hepatitis and alcohol use disorder who presented to the emergency department with alcohol withdrawal and intractable vomiting. After 4 to 5 days of heavy alcohol use, she had multiple episodes of non-bloody emesis, and hours after her last drink, she developed upper extremity paresthesias, which were consistent with her prior alcohol withdrawal symptoms. She had a history of prior hospitalizations in the setting of alcohol use and withdrawal. Noteworthy complications from prior admissions include acute kidney injuries, rhabdomyolysis, hypokalemia, anion gap metabolic acidosis, and QTc prolongation, just to name a few. En route to the emergency department, she received 2 liters of IV fluids, Librium, lorazepam, with improvement of her emesis, but she continued to have nausea. Hospital course. Vital signs on her presentation were only significant for tachycardia. An EKG that was obtained upon her arrival, shown in Figure 1, showed upsloping T waves with an amplitude of 10 milliseconds in both the precordial and limb leads, fulfilling criteria to be described as, quote, peaked. The QT-QTC interval was also prolonged at 502 and 627 milliseconds, consistent with hypokalemia, leading to prompt evaluation and attention to her management. Serum electrolytes were evaluated as the patient's presentation of intractable vomiting was inconsistent with the EKG findings. Initial laboratory tests were most significant for hyponatremia at 124, hypokalemia at 3.3, hypochloremia at 81, an elevated creatinine at 1.64, and a phosphorus of 1.6. The serum panel was repeated from a different peripheral site just to confirm that the electrolyte deficiencies prior to initiating treatment. To add further complexity to her case, the repeat serum test revealed a potassium of 5.8, leading to yet another draw, which revealed a potassium of 3.3, confirming that the second draw was likely elevated in error. The patient was treated with oral potassium chloride, IV potassium phosphate, and another liter of IV fluids, along with symptomatic treatment of her ongoing nausea and withdrawal symptoms. A repeat EKG showed improvement in both her T waves and QT-QTC interval. Her symptoms of nausea and paresthesias had also resolved, and at this time she was able to take food by mouth without vomiting. Following the correction of her electrolytes and abnormalities and the improvement of her EKG, she was deemed stable enough for discharge. Moving on to our discussion. In hypokalemia, the EKG changes typically follow a characteristic pattern as the electrolyte deficiency progresses. Initially, hypokalemia causes the depression of the T wave and then the elevation of a U wave. As this progresses, the T wave becomes smaller and the U wave increases in size. Increasingly severe hypokalemia will eventually cause premature atrial contractions and premature ventricular contractions, which may further deteriorate into ventricular fibrillation. The EKG findings of both the progression of hypo and hyperkalemia are displayed in Figures 4 and 5 respectively. So why did this patient present with EKG findings that were not only abnormal for hypokalemia, but actually indicate the opposite diagnosis with regards to her electrolyte abnormalities? There have been reports of patients with similar findings with the theory that the positive T wave at times may actually merge with a positive U wave, which causes what appears to be a large T wave and a prolonged QT. The cause of this patient's EKG variation may be multifactorial. Her peak T waves may be a consequence of that T and U wave merging, but there have also been instances where hypomagnesemia causes peak T waves. This patient had evidence of hypomagnesemia on labs as well. One of the major points of this case discussion is the reminder to always challenge the clinical schemas that we have developed throughout our medical education. Buzzwords and buzz findings get us through boards, but when it comes to real clinical practice, always bear in mind the atypical presentation of a typical finding. In conclusion, there are a few pearls to extract from this case. Hypokalemia should be suspected in a patient regardless of T-wave morphology and U-wave presence, given that the EKG finding has a prolonged QT interval. Furthermore, the morphology of a peak T-wave is generally described as having a more narrow base, whereas that of a U-wave is more broad-based. Both of the prolonged QTC and the broad base likely of the combined T and U-wave were consistent with the EKG findings that we found in this patient. This case also highlights the importance of clinical context when it comes to comprehensive management of patients with electrolyte abnormalities. In this patient's case, her intractable emesis in the setting of heavy alcohol use was the cause of her potassium depletion. Additionally, this case illustrates the importance of electrolyte confirmation through serum tests when abnormalities are found on EKG, and the association between a certain EKG and the electrolyte abnormalities are not always absolute. The prompt treatment of this patient's peak T waves without confirmatory evidence of hyperkalemia may have led to further worsening of this patient's hypokalemia and placing her at risk for fatal arrhythmias. Thank you so much for listening to this presentation.